I can start. Okay. Ravin.
Sir, it's a circular stapler, sir. And
Is it
the
circular stapler? No.
yes, sir.
No. What is this?
Yes, sir. Yes, sir. This is
It
circular
is a form
stapler.
of circular stapler, but what is it? What is this used? Come on, man, Praveen, you must have assisted for many procedures.
Yes, sir. Will you be using the APR, sir?
No. Look at that. If you are not sure, I'll go to Nikitha. Nikitha, what is this?
Circular endostapler, sir, which can be used for the anastomosis or for the stapler hemorrhoidectomy.
Nikitha, both are different.
You can't use this for it's one anastomosis, man. That is different. They are different. This is stapler hemorrhoidectomy. This is a form of circular stapler, but this is stapler hemorrhoidectomy stapler.
So we can use for both, no, sir. Anvil
It
and
is
the
not common. It is not common. They are different. Although it is a form of circular stapler, stapler hemorrhoidectomy stapler is different. Their sizes are also different.
Okay.
Okay, anyway, what the parts label this one. So name the label parts. What
Yes,
is
sir.
one?
One will be the cartridge, sir. 2 is shaft. 3 is window. 4 is handle. And 5 is protector, sir. 6th will be the anvil. 7 is safety. 8 is trigger. 9 will be adjusting nut, sir.
Okay. What are the problems associated with this instrument?
There can be bleeding from the staple line, sir. Or
Is that
stapler misfire.
something to do with instrument, or is it to do with the procedure?
Procedures.
When will you encounter bleeding? I think you will not have so much time. Nikitha, when will you encounter bleeding if you use this instrument?
if any vessel is involved within the staple line, sir.
No, it will staple across the vessel. So why should it bleed? Nitya or Sanya or even Ainaz and Samir if they know the answer. I've told you all many times. I think Niranjan must have also told you.
When the purse string is not completely taken, and the complete donut, like, if it is not formed during the this
If
thing.
the purse string, if there is lot of gaps between the two sutures, from those gaps you can have bleeding. And second, Tanya,
And if the trigger is not completely at one go, we have to completely lock the
And that,
like
yeah, that's okay. Yeah, if you do technically, if you don't do it properly also, but what other reason why you can see bleeding? If the staples doesn't fire properly, that is obviously instrument failure. If the staple fires, but there are gaps in where the staples are not fired, there you can have bleeding. And if the hemorrhoids are huge, despite you taking proper bites, they can bleed. So then those places you may have to apply sutures to stop the bleeding.
And fourth, when you don't give adequate time for the tissue hemostasis, that
Yeah,
is why we wait when we take the pulse string and before firing, when we lock it, we wait for some time. And also,
yeah,
once we fire, we hold it for 30 seconds at least,
yeah.
so that it achieves proper hemostasis.
So what other complications? You said bleeding. Come on, man, Nikitha, others, you should be able to say taka taka taka. This is not that complicated. What are the other complications associated with stapler hemorrhoidectomy?
Uh, staple misfire malfunction, sir.
Malfunction
Bleeding.
and yes, and then so there can be the mucosa to mucosa approximation may not be there. So there can be gap in the mucosa. Yes, okay. Then what else? Anteriorly, when you take the bites, what happens? Especially in women
Urethra.
and men. In men, what can happen? In women, what can happen?
Fistula into the urethra, sir, like urethral injury leading to
Urethral injury, urethral fistula, vaginal fistula,
vaginal.
rectovaginal fistula, prostate, in injury to the prostate can happen. And there can be anastomotic breakdown, and there can be even necrosis and fistula formation. So all of these are potential complications. So you have to be guarded against that.
So there can be a leak also.
Yeah,
The anastomosis breakdown, which lead to perianal abscess or sepsis spreading higher up, where you might have to do a colostomy also. It had actually happened in our own hospital also, where the
ಹೌದಾ?
colostomy had to be ಆಗಿತ್ತು ಒಂದ್ಸತಿ ಸುಭಾಷ್ ಸರ್ ಕೇಸಲ್ಲಿ, where he had done stapler and it led to perianal sepsis, and Lakshman sir ಮತ್ತೆ sir had to do long time back, had to do a colostomy diversion for the
Okay.
wound to heal,
Ah,
and eventually they reversed later.
okay.
So but it can happen if you take too thick a tissue and take the muzzle and take it and then staple it, so the line will be the whatever the anastomosis happens will be a thin line which will only include the serosa, so that will open up and lead to sepsis.
Yeah,
So that is why you never take the muzzle, you take only the mucosa and submucosa.
correct. Okay, next. Any other questions, Niranjan, on this?
And nothing else, sir, ಅಷ್ಟೇ.
Okay, next.
But how to manage that bleeding ಅದನ್ನ ಕೇಳ್ಬೋದು.
How to manage the bleeding, Praveen?
Sir, first we should pack the wound, sir. Pressure.
Difficult to apply pressure, no? How will you apply? You can apply pressure, but
Yes, sir.
use a sponge
Then,
on a stick or something and apply pressure. Yes.
sir, then I have to take suture ligation, sir.
Preferably
Around the
suture
bleeding
ligation.
point.
Don't
Yes,
try to use diathermy, because diathermy cannot usually control this bleeding. So
Yes, sir.
you either, as you said, pressure or suture.
Yes.
Unless it's a very small, tiny amount of bleeding, you can just you can use a diathermy then. But generally, preferably pressure or suturing. Okay.
Yes.
Okay. Next question. So the homework is for Praveen, Nikitha, and others. How is the stapler hemorrhoidectomy CEA stapler different to the usual CEA stapler? that we use for end-to-end anastomosis.
Yes, sir.
Okay. What is this surgery? Indications, follow-up, alternatives. Praveen,
Sir,
quickly.
this is an set-on surgery, sir.
Ah,
Indications is for high fistulas, complex fistulas,
ah,
and fistulas due to Crohn's diseases.
okay.
And-
Intersphincteric fistula, intersphincteric
Sir,
transsphincteric.
Transphincteric, extrasphincteric fistulas, sir. High fistulas.
What is the rationale or principle behind using ceton? How many types of ceton do you know?
Sir, three types, sir. Loose setons, cutting setons, and hybrid, sir.
Ah,
Loose setons will be mainly for draining for long periods, sir. Cutting setons for cutting through the muscle and healing, sir. Hybrid
okay.
will be using both techniques, sir.
So what is the purpose of a loose ceton?
Sir, it's for draining the fistula, sir, for longer period.
Draining the abscess.
Yes, sir. No.
So when there is a lot of sepsis, it facilitates drainage of abscess. So what do you do when you use cetons for Crohn's disease? How do you
Crohn's will
manage
be
the
using
patient?
cutting
Patient,
setons.
you use cutting cetons or you use draining cetons?
Cutting, sir.
No, but usually with Crohn's, what is the things that you see? How is it different from an ordinary fistula in secondary to cryptoglandular abscess?
In Crohn's fistula, what is the treatment, Praveen?
Not cutting, man. So what do you do? What is the difference between a cryptoglandular fistula and a Crohn's fistula, or even, for example, malignant and LGV and other fistula, secondary causes or radiation?
Sir, in
Nikitha?
Crohn's, it is due to
Crohn's it is
in
due to
Crohn's,
what?
it is due to chronic transmural inflammation, sir.
Okay. So what will you see? Nikitha or anybody else?
So, granulomatous changes and due to the inflammation, the fistula is formed, sir, here.
No, that don't go to pathophysiology. I'm asking about essential difference with cryptoglandular and Crohn's fistula. It's multiple, man. Usually Crohn's fistula, you will have multiple fistulae. That is why whenever you see multiple fistulae, you don't think it is cryptoglandular, because cryptoglandular usually it is single. It can branch and all that, it can be complex, but it is usually single. The external opening will be always single. If it is multiple, always suspect secondary, especially Crohn's disease. So when you have that, you use loose cetons for drainage, because there will be a lot of sepsis due to inflammation and infection. So put the multiple cetons. After that, what do you do, Praveen? What is the treatment of choice for Crohn's fistula, perennial water, what they call as water can perineum? Anybody? I think, yeah, we had one patient. I think sir also talked about it in one of his classes, and we had one patient, at least mine, in Sagar, which we treated with that. Biologicals, man.
Biologicals.
Yes, sir.
Biologicals is the treatment of choice, and that is, it has got excellent results, especially for perennial Crohn's disease. For others, it may be debatable, but for perennial Crohn's disease, you put cetons, and then if the sepsis is very severe, you can even give them a colostomy. Otherwise, you put cetons to drain and start them on treat the sepsis. Make sure that sepsis is healed before you start, because otherwise, with the biologicals, the sepsis will cause very severe sepsis will aggravate, and the patient can actually even die. So you have to be very careful. But treat the sepsis. Make sure that the drainage is minimal before you start biologicals, and within 4 to 6 weeks and I think it's usually 6 months the treatment, you will have complete resolution of sepsis, this one fistula. Then for maintenance you may have to give it, but that depends on the severity of Crohn's disease. So explain to me the principle of this one, what do you call, tightening fistula, the setons which are tightened.
Sir, it creates ischemic necrosis and slowly divides the muscle, sir.
Okay, and
So-
then it allows the muscle to heal.
Yes, sir. And heals from inside to outside. Sir.
Okay, so how frequently do you do this? How do you tighten it?
Sir, we'll ask the patient weekly once to pull the knot slowly outside, sir.
You can't ask the patient to do it, man. They will have to
Relax.
come to you and you have to do it. Because first of all, they will not be able to see it. And second, they are not educated enough to do all these things. So you have to call them for outpatient visits and tighten the seton. After tightening, you'll have to probably put a knot at the where you have tightened, and again next time when they come, you tighten it further, and slowly it will cut through, and as you said, it will cause fibrosis of the first it will cause necrosis and then fibrosis of the muscle, and then it will heal. So because you are doing it slowly, it doesn't cause incontinence. So what are the guiding principles of treatment of fistula? Which are the two important things you need to, three things actually. So what are the three guiding principles of treatment of fistula? Praveen.
Sir, to identify the cryptoglandular sepsis.
No, that is not guiding principle that you have to do anyway.
To identify relation of fistula with anal sphincter.
No, all those things you have done. No, but what are the three principles when you treat the fistula? You are doing all the things, either MRI or transrectal ultrasound, and you identify whether it is branching, whether it's complex, whether it's simple, low, high, intersphincteric, transsphincteric, supralevator, all those things you have identified. But as a common theme for all of the fistulas, what are the three things you have to worry about?
To completely remove the tract, to drain
Okay.
all associated sites of infection,
Yes,
to preserve
So-
anal incontinence.
correct. Control of sepsis and extirpation or removal of the fistulous tract and maintenance of continence. So you have to, these are the three things you have to, these are the three guiding principles. Okay. What are the alternatives to seton?
Sir, latest you can use WAFT, sir, video assisted anal fistula tract ligation. There is fibrin glue or fibrin plug.
What is the success rate of fibrin glue or fibrin plug?
It's very less, sir.
How much?
Percentage I don't remember, sir.
Nikitha? Anybody
Sir,
else? Nikitha. Tell some figure.
They're still on the trial phases, sir. Figures I'm not sure of, sir.
Sanya or Nitya, Ainaz, Samir, anybody?
Not sure, sir, about recurrence.
Usually they quote figure of about 40-45%, that's all. I think Niranjan, am I right or is it even lower?
Sir, correct, sir. Around 30 to 40%, as I has that 30 to 40%.
40%, that is all. So not very good. Waft though, I'm not sure how good it is. I think recurrence rates for that also is quite high. So cetons are probably the most safer of the methods, especially for this one. This lift procedure and other things are there. Lift procedure probably has a better for complex and high fistulas. There, I think there is one fellow. I don't know where he is. He's in Haryana or Rajasthan somewhere. He's one of the definitely authorities in India. I think he may be one of the authorities in the world also. I think what he does is the lift procedure. I think he's got very good success rate of about, he quotes about 75 to 85% for the high fistulas. But it is I think the whole process he need for a regular follow up and very the post operative care is extremely important in these procedures. What he was describing. I forgot his name.
There are two people. One, the least rate of recurrence is with complete excision of the tract and sphincter reconstruction.
Yeah.
Highest number is by one person called as Dr. Parvez Sheikh. He's from Mumbai. And another one is one person called as Samrat Jankar. The newer procedure, what they talk about is PILTEC, proximal intersphincteric fistula tract ligation, where they excise the internal opening and the internal sphincter, and then they excise the complete tract and resuture the external sphincter, only the external part. So that is probably that probably has the least rate of recurrence, but you should have the technical skills to identify the anatomical structures and reconstruct.
Okay, next question. Any other questions, Niranjan?
Nothing else, sir.
Okay, next question. Okay.
Great stiffness veins. It can be used in vascular reconstructions. As graft.
And what else? What else can we use it as? You said vascular reconstruction. You can also use it for
CABG.
Huh?
CABG, sir.
Coronary artery bypass.
Coronary artery bypass graft, man. Can you not use that?
Yes, sir, can use, sir.
Do you use how do you know the methods of using saphenous vein?
Reversed
It's
saphenous.
Saphenous vein. Why do you reverse it?
Due to valves, sir.
To change the
Valves are
valves
present.
direction.
Okay.
Direction.
So if you don't want to reverse it, what do you do?
Strip
There
off
is
the
a
Strip off the valves.
valve ablation can be.
Yeah, you can do in situ. That is, you keep the vein as it is, and then there is a valvotomy. You can under vision. You can there is a camera that you can use to ablate the valves, and then use it in situ. You can anastomose it to the femoral artery, which is next door, and then you can anastomose it to the distal vessel, whichever you want. So you can use it in situ or reverse saphenous vein graft. Okay. I think there are not many questions with this. Next one.
These are compression stockings, sir.
Um,
Four classes are there. Class 1, 14 to 17 mm of HG. Class 2, 18 to 24. Class 3, 25 to 35. Class 4, greater than 35, sir.
So uses of each of them. Uses of each of them.
So class 1 is for reticular veins and telangiectasia, sir. For varicose, we'll be using class 3, sir.
Class 2 for what? What do you use for DVT prophylaxis?
Class 2, sir.
Okay. And class 4 for? Where do you use class 4?
lymphedema and
Who said that?
me, sir.
Ah. So no use of class 4 for venous disorders? Nitya?
Sir, only in chronic lymphatic insufficiency, lymphedema, they use class 4, sir. And the two they need to decompress. There's a special stockings kind of thing which they have to inflate and deflate at a particular time interval, sir, for lymphedema, sir.
So venous disorders, class 1, 2, and 3 usually. Is that correct?
Yes.
Yes, sir.
Yes, sir.
Okay. Any other questions on this? Nitya, Sanya?
Praveen, what is 4-layer bandage and what are the 4 layers in a 4-layer bandage?
4-layer bandage will be using in as an for varicose ulcer.
Components? What are the 4 layers from inside to outside?
He doesn't know. Nikita? That's why I keep telling you guys, you have to watch them whenever it is done. Very important. Nikita, don't you know?
Yes, sir. So from inner to outer, sir.
Ah,
Gauze, a padding layer, then wool layer, and then finally crib bandage, sir.
what wool layer?
Final is not crep bandage. There is something about that.
Cohesive bandage, ma'am. Compression and then cohesive.
What bandage?
Like co bandage, sir.
Co-band
It's
bandage.
cohesive.
Cohesive. Okay. Nitya, tell them. Ma.
Sir, first is the wool layer, that is orthopedic wool that we use, and then second will be the compression bandage, and third will be a elastic compression bandage, and fourth will be the co-bandage, sir. Sometimes they use even the duct tape, like in government setup, if there's no cohesive bandage, they even use the duct tape as the fourth layer, sir. And what is Biscard regimen, Praveen?
Same for varicose ulcer basic. It is education of patient, elevation of limb, applying of elastic compression stockings.
And one more thing.
Exercise, ma'am.
Exercise, and also previously they used to say dipping the limb in use all solution. That is also there.
So how long do you keep the 4-layer bandage, ma'am? Praveen? Once in how many days? Homework or anybody else will say? Tell the answer. Homework.
48 hours we have to change, sir.
48 hours, sir. No, no, no. Wrong answer. Okay, right. Next question. Niranjan, any questions?
No, sir. No, sir.
Okay, next. Praveen. What is
Gas
this?
and is
No, no, don't say gas and
yes, sir,
dye
yes, sir, yes,
acoustic.
sir. It's an chest X-ray of PA view.
No, what?
Yes, sir.
It's erect chest X-ray, no?
Yes, sir.
They should mention.
Yes, sir. Chest X-ray of PA view. It showing gas under diaphragm on right and left side, sir. Both sides.
So, which is the gas in the, so, Nikita, show the pointer. Which is the gas on the right side? It's obvious. Left side.
Yes, sir.
And where is the fundal gas bubble? Below that. Below that, the faint one is the fundal gas bubble, and this one is the gas under the diaphragm. What are the common conditions where you get gas under the diaphragm?
In hollow viscous perforation, sir.
Yeah, okay, that that is obvious. What are the most common things? Is this small? Is this minimal quantity or is it large quantity gas?
This large quantity only, sir. There is bilateral.
So, what are the common causes for this kind of gas under the diaphragm?
Duodenal perforation
Okay, then
and small small intestinal perforations.
so you won't get it in gastric ulcer perforation or in large bowel perforation.
We get it in gastric perforation also get it. Yes.
So gastric, duodenal is common. Second common is what?
Small
Large
intestine,
bowel,
sir. Second.
large bowel perforation. Small bowel perforations is now less common because usually it used to be due to what? Small bowel perforations.
Typhoid ulcers, sir.
Typhoid ulcer. Typhoid is now much less common, right?
Yes, sir.
Can still happen, but not so common. So large bowel perforation and duodenal ulcer perforation, they are the two commoner conditions. Can you get gas under the diaphragm with appendicular perforation?
No, sir. Very minimal, sir.
Where can you get gas under the diaphragm in appendicular perforation? If there is perforation at the base,
Yes, sir.
so then you can have gas, gas under the diaphragm. Not otherwise. Usually, where is usually the tip that is perforated.
Yes.
Okay, how do you manage?
So, first initial resuscitation by starting IV fluids, nasogastric tube insertion and decompression, and Foley's insertion and urine output monitoring, and to start an antibiotic, sir.
You missed an important thing. You mentioned all of that, but what do you do first when you see the patient? What do they come to you with? Nikitha?
Pain,
Severe pain.
analgesia and PPS will be starting.
Yeah, you have to give analgesia, no? So make them comfortable. Otherwise, because of the anxiety and the pain itself, the nociceptic stimuli will, cause changes in blood pressure, heart rate, and all that. So you have to give them analgesia, make them comfortable. Then, as you said, IV fluids, urine output monitoring, antibiotics, nasogastric aspiration. Yes. Okay. So when will you operate on these patients?
You have to operate immediately. It's exploratory laparotomy you have to do and
No,
identify the
when?
perforations.
When?
Depending upon the patient's general
Patient
condition.
after stabilization.
Yeah, that is generally the rule, but the current thinking in England is, I don't know whether that is the same in US. In England is now that you don't wait for till the patient is fully stable. You resuscitate the patient as quickly as possible, maybe an hour or two, and then immediately shift the patient to the OT and deal with the cause of the problem, and then resuscitate the patient after the patient has been after the problem is being tackled. So there are probably pros and cons to that approach, but generally, what we do is to give them an hour or two to stabilize them. Make sure there is good urine output, fluids are given, IV antibiotics are on board, and then you take them up for surgery. So, what kind of surgery are you, contemplating, Praveen?
Sir, diagnostic laparoscopy or exploratory laparoscopy? Sir?
Okay. So, what will you do?
I'll do a diagnostic laparoscopy, sir.
So, you do a diagnostic laparoscopy. Do you feel confident enough to handle the problem if you encounter, let's say, duodenal perforation or,
And
sorry.
sir, once the perforation site has been identified, then I can convert it to open, sir.
Okay. At your stage, that is what you should say. I'll do a diagnostic laparoscopy to. Is there a role for CT scan in these patients?
If patient is
Can help
stable
in-
enough, we can do a CT scan to localize the
Site of perforation. Okay. Right.
Is it commonly possible for them to pinpoint the site of perforation? What is the sensitivity and specificity of CT scan in terms of perforation? Sanya, Nitya,
probably around 60 to 70%, sir.
that is a guesswork, or do you know the figure?
Yes.
Nitya, Sanya, Ainas, why are you silent? Sanya and Ainas and Samir, not opening your mouths at all. I told you Praveen and Nikitha first, but you are not excluded from the class.
Sir, I'm not sure, sir. Like you can't always detect it, sir, but I'm not sure about the percentage, sir. Like sensitive.
Again, homework. I think you need to take down what are the points for homework and post it. Otherwise, there is no point. No learning in this.
Yes,
Niranjan,
sir.
questions?
Nothing else, sir.
Sir, I
So,
want to ask a question.
just a
Uh,
minute, Nikita, Nitya.
yes.
Niranjan, is
Yes,
it
sir.
acceptable if he says that at my stage I will do diagnostic laparoscopy, identify the source of perforation and then convert? That is an acceptable answer, right?
That is what, again, it will depend on where he is giving the exam. If it
Ah.
is in medical college, it is better to tell that
Straight away say
both options.
laparotomy.
Both options. I will probably do laparotomy. If the expert is available, the diagnostic laparoscopy is also a way of managing it.
Yeah.
So let him, he probably has to be diplomatic.
So, Praveen,
Yes, sir.
but certainly don't say I will suture the perforation and all those things.
No, sir.
Laparoscopically, you first say, if it is come to me in an emergency setting, I will do an exploratory laparotomy, identify. If expertise is available, option of laparoscopy, diagnostic laparoscopy and laparoscopic management is also there. So you escape like that. Don't straight away jump and say that I will do diagnostic laparoscopy and laparoscopic suturing. They may not like it at
Yes,
your
sir.
level.
Yes, sir.
Okay. Right. Nitya, question.
Just a practical question, Praveen. You have a patient with the same guarding rigidity and you're suspecting a perforation. And in the X-ray, you're not able to identify the air in the diaphragm and you don't have CT. How will you demonstrate air in the diaphragm? First X-ray, you're not able to pick up the air, but then you don't have CT. You have 100% clinical suspicion it is a perforation. How can you elicit the air under diaphragm in an X-ray?
Which film will you take? Praveen?
Which
I
film
tell
and anything else that you can do to enhance or to
Nikita? You can put the patient onto a
In lateral
flat
position.
Lateral
decubitus.
decubitus.
let left lateral decubitus position and see if there is any air under the diaphragm. Even very small amounts of air will be picked up. If you can't, then as Nitya said, there is another maneuver. What is that maneuver? You would have passed a nasogastric tube, right?
Hmm.
Yes, sir.
Yes, sir.
So what will you do? Put some
Take
air
a-
through that and see if there is any air that escapes into the general peritoneal cavity. But that is only true for duodenal ulcer perforation or
Duodenal.
gastric ulcer perforation. It can't be done for others.
Yes, sir.
But generally, the answer they expect is lateral decubitus, especially left lateral decubitus position. It is better for picking up very small amounts of air under the diaphragm. If it is not obvious on the erect chest X-ray or erect abdomen. Okay.
Yes.
So management is basically identification of the perforation wherever it is. If it is a large bowel perforation, what will you do, Praveen? Large bowel perforation.
It is
Usually due to
doesn't
what?
complete.
What is large bowel perforation due to? What are the common 3 conditions or 4 for that matter? What are the 4 causes for large bowel perforation?
Sir, diverticulitis, sir,
Yes,
due to carcinoma,
yes,
volvulus,
yes. 5 in fact. Inflammatory bowel disease
IBD.
and tuberculosis. Inflammatory bowel disease, is it more common with Crohn's or with more common with the ulcerative colitis?
ulcerative colitis, sir. Perforation.
Correct. Because of what is that condition called?
Uh,
Toxic megacolon. Okay,
Yes,
so
sir.
toxic megacolon with perforation. Crohn's disease more common to cause obstruction rather than it can cause perforation as well, but internal fistulation, sepsis, and obstruction, those are more common with Crohn's. Perforation is more common with ulcerative colitis.
Ulcerative colitis.
Tuberculosis, don't forget tuberculosis. Okay,
Yes, yes, sir.
okay, right. So it depends. So the management of large bowel perforation depends on the condition. Will you do a resection anastomosis?
It is an large and
The answer is Nikitha. Will you do a resection anastomosis?
Depending upon the perforation, sir.
And
The segment where the perforation is.
the health of
viability
the
of
bowel, contamination, presence of
Nutrition
severe
status of
sepsis,
patient. Yes.
pus, and the patient's condition. So all of these factors have to be considered before you think about resection anastomosis. You can definitely do resection, then do what? Bring out what?
Either we can bring out a end colostomy, sir, temporary end colostomy, or
Yeah.
if we do an anastomosis and ileostomy, depending upon the all the factors involved, sir.
Okay. So generally, at your stage, you should say, I think all these things are there, but generally I would have a very low threshold for bringing out a stoma.
Yes, sir.
Okay.
Yes, sir.
Okay. Right. Next question.
So one more small question.
Ah,
How long will a post-op pneumoperitoneum be? Immediately after the post-op, you see a erect X-ray and you see pneumoperitoneum. So how long can that post-op pneumoperitoneum be there in an X-rays? That I wanted to ask.
yeah, good question. Praveen,
24 to 48 hours, sir.
Nikita,
It can stay up to a week, sir, as per the articles previously, but usually get absorbed in the next 2-3 days. can stay up to 1 week.
It's up
Samir,
to
Ainas,
Sir, it usually resolves by 1 week, sir.
Ainas,
Yes, sir. The like roughly around 1 week, sir. Like,
Nitya,
Sir, it is 5 to 7 days, sir.
correct. Usually 5 days, very rarely up to 7 days. Niranjan,
Sir,
pneumoperitoneum.
huh.
Usually stays up to 5 days. What we usually expect, maximum 5 days. Sometimes it can be up to 7.
It can be up to 4 weeks also. Post laparotomy, sometimes it can stay. Laparoscopy they say up to a week, but sometimes laparotomy as long as up to 4 weeks, 2 to 4 weeks it can stay.
So that is why don't think gas under the diaphragm is one of the things that you can count on when you are assessing a post-operative abdomen, which is very difficult anyway. So gas under the diaphragm does not contribute much in a post-operative status, unless it is a huge amount of air. Right. Now, diagnosis, Praveen,
The hydatid cyst in the liver, sir.
only liver. See, this is where, no, who's showing all that? Don't do all that. Where else is it there, man?
The spleen, sir.
And
And
what else? Now show the thing. Nikitha, show him what is abutting the gastric one. Not that. Where is that?
clean.
Is it in the spleen or is it in the peritoneum? There is a lot of free fluid, no?
Yes,
There is
sir.
a lot of fluid around. So it could probably it has ruptured. It is in this much that the stomach one that is abutting the stomach probably is in the general peritoneal cavity. So etiology everyone knows. Complications, Praveen.
In the liver, it can cause pressure effects, causing obstructive jaundice, portal hypertension, Budd-Chiari syndrome.
Portal
And-
hypertension.
Yes, sir. Compression of portal wing.
Is it that common? Portal hypertension, I have not read. Portal
Pressure
hypertension,
effects.
it can cause obstructive jaundice, I agree. First thing is what? What is the first thing that can happen if it ruptures?
So if direct rupture can cause anaphylactic shock, sir.
Anaphylaxis, yes. Then what else?
So, it can be communicating rupture, sir. It can cyst can rupture into biliary system, sir. It
Correct.
can cause obstructive jaundice, cholangitis.
Yeah. Then it can rupture into
And-
what else? If it is in the segment 5 to 8.
It can go into intrathoracic extension, sir.
Correct.
Into the pleura lung.
It can cause pulmonary
empyema.
hydatidosis.
Yes, sir.
It can rupture into the general peritoneal cavity. Can it go to brain? This hydatid, this is described in the brain. Bone, it is described, right?
Yes, sir.
Liver, kidney, spleen, pulmonary, and into the bone.
Yes, sir.
Sometimes even into the pericardium they can rupture, sir. Yes.
If it is in the left lobe of the anatomic left lobe, it can rupture into the pericardium also, because it is just under the diaphragm. Okay, how do you treat this particular thing?
Sir,
Ravi?
yes, sir. First, we'll start with albendazole, sir.
Hmm.
400 mg per day, 1 week prior to surgery, and will be
1
continued
week
up to
alappa in this patient. 1 week is not sufficient. How many?
What is the recommended standard
Ah,
recommendation?
ಸುಮ್ನೆ ಏನೋ
What,
ಹೇಳ್ಬಿಡೋದಲ್ಲ.
one.
what is the one? The actually you might have to give it many multiple times in a cycle. So what is the recommended thing? Minimum thing where you have to give
Before
to
you
achieve.
even think about operating.
1 to 6 months, sir.
No. 12 to 6 months.
One, sir.
One. 4 weeks. Okay.
4 weeks. Okay, so minimum of 4 weeks before you even consider surgery. So not just say something 1 week and all that. How can you say, flippantly 4 weeks minimum? Okay, so
And
after
if it
4
is,
weeks,
and if there are multiple large ones, you can repeat also after giving a break. Why do you have to give break, Praveen, after 4 weeks?
For them to
in sim-
transform into the receptive state, sir, like
No, nothing to do with that. It is to do with the drug which you are giving. I have given you a clue.
suppression.
Huh?
It causes marrow suppression, sir, albendazole.
It causes neutropenia. So you have to give a break
break.
of 1 to 2 weeks, and then you can again give one more cycle. So at least minimum you have to give one cycle at least before you operate.
So how do you operate, Praveen?
We'll be using the pair technique, sir.
What technique?
Pair, sir.
Pair is different, Praveen. Pair is a different procedure altogether. When will
I
you do
asked-
pair?
So when there is multiple, this is
Oh, so how will you do pair in them if there are multiple cysts?
What will you do for this patient, man? We have got this patient here. What will you do?
total pericystectomy, sir.
Will you open or laparoscopy?
It can be done by both, sir, based on surgeon's choice.
What will you do for the spleen?
Sir,
Do you have to operate every time?
Can you manage it conservatively? Is that what Niranjan is asking?
if it is based on size and complication, sir. If it is up to 7
No,
centimeter,
I'm asking you a direct question. Yeah,
yes, sir.
tell me the answer.
This is a larger size, sir. If and it has so I have to operate it, sir. It is greater than 7 centimeter.
Even if it is asymptomatic. Suppose in this patient, if patient doesn't have any symptoms, can you manage conservatively? Because it is involving the spleen and all that. Patient is asymptomatic. You have detected incidentally on some ultrasound, then you have done CT, and this is the finding.
Sir, if it is C4 and C5, then we'll do the wait and watch, sir.
What is
that
it?
is
C4?
inactive.
What?
Inactive hydatids, sir.
How will you know that it is inactive?
Sir, based on the CT findings, sir.
Can they say it is inactive or active based on only CT finding?
Yes, sir. Based on that classification, they'll give, sir. CE4, CE5.
No, in the beginning only, even without treatment or anything, straight away will they be able to tell?
Yes, sir. Based on that cyst imaging, we can tell, sir. If there is active daughter cyst, sir.
No, correct. So in that, how will you manage?
You have to read up, Praveen.
I'm asking you, non-operative management, can you do? in these cases when they have multiple cysts which are small but involves liver, spleen, extensive. Can you just manage them by giving albendazole, maybe 1 or maybe 2 cycles, and then keep quiet? Do you have to operate all the time? So this is you have to read up and let us know in the group.
Yes, sir.
Yeah.
Yes, sir.
So coming to surgery, sir asked you some question. Pair is different. Pair is what? Full form.
Puncture, aspiration, installation, reaspiration, sir.
Percutaneous, that is.
Yes, sir.
So in surgery, what you do? How will you do? That is what sir asked.
Surgery will be doing the sir.
In surgery, we try to remove the cyst without puncturing it,
complete
sir.
system.
Complete.
No,
Very
you have to.
cystectomy.
No, you
You have
can't
to
do that.
remove the. You have to puncture. You have to do something before you go and remove the cyst. Why do you have to do that?
It's colicidal, sir, to
Colicidal
inactivate
agents,
the
sir.
whole cyst.
What do you mean by
To
scolicidal?
prevent, sir.
What do you mean
So
by
to prevent-
scolicidal agents?
So to prevent anaphylaxis of if there is spillage, so we'll be using the
No,
colicidal
it is not
agents.
to prevent anaphylaxis.
Prevent
It is to
the
prevent.
hydrated cyst spread, sir. Like the active
Daughter cyst.
agent.
One at a time. It is to prevent what?
To prevent the spread of the hydrated cyst
Why are
procreation.
people
sir.
struggling
Daughter
so
cyst.
much, man? It is to prevent spillage and recurrence.
Recurrence.
So you have to do that. So scolicidal agents are to kill the daughter cyst, active daughter. So what will you do then?
So what
Without
is the
puncture, how will you
procedure?
instill?
What is the procedure done? Nikita, I have to explain to you, all of you. So what you do is you make an incision over where the cyst is and immediately insert usually we use 10 mm suction because 5 mm it will get clogged and it will not be able to aspirate it. So under the direct vision, so camera also has to go into the cyst and the 10 mm suction has to be inserted in, suck out all the daughter cysts and the sand and everything. And then, as Niranjan said, after you have sucked it all out, instill scolicidal agent. What is the usual thing that we usually use?
Or you can use 20%
Better.
saline, 3% hydrogen peroxide, or 1.5% cetrimide, sir.
Okay, any of those things,
Which is the safest?
which is safest?
20%
What will
saline.
cetrimide cause?
Cetrimide.
Hypertonic saline. So what can
Hypertonic saline is safest.
what can sir asked you some question? What can cetrimide cause?
See, you will not know whether there is any communication with the.
Biliary tree.
So what will cetrimide cause?
Cholangitis, sir. In that.
It can cause biliary cirrhosis as well as it can cause anaphylaxis, chemical peritonitis also. So you have to be very careful when you are using cetrimide. Always probably you have to use a diluted this thing. Don't use a concentrated cetrimide directly.
Usually safest to use, as Niranjan said, hypertonic saline.
saline.
There's no side effects as such. So how long do you instill it for? All these things you should know. Again, homework. You are all writing it down, no?
Yes, sir.
Yes, sir.
So what is the other problem after you, let us say you have instilled hypertonic saline for some time, then you have removed all the daughter cysts and everything. What will you do with the cavity? Cavity is still there.
Sir, you can do omentoplasty, sir.
You can put the momentum in, and then will you put a drain inside that? Drain the cavity or not?
We can use a drain.
Not you can
No.
use, you have to.
We
You have to
yes,
use
sir.
it. So why do you use drain? You use it for two purposes.
Sir, for irrigating that cavity, sir, with saline
No,
solution.
you don't irrigate them. After you have instilled the thing, there is no need to do it repeatedly. But why do you use a drain? Nikitha or anybody else?
The secretions are expected from the
So you have
cavity.
to drain the cavity as because the cavity will continue to secrete, fluid, and then it will usually slowly shrink. That is one. But more importantly, why do you use the drain? Because you will know whether there is bile leak or not. The bile leaks may not be obvious as soon as drained and inspected the cavity. It may happen later. So you want to know whether there is any bile leak. What if there is bile leak? If you see it on the table, you can definitely suture it. But what if it is found out later? What will you do?
Sir, if the leak is minimal, we can wait and watch, sir. But if it is
Okay.
significant, we have to go for an MRCP or further evaluation to see the point of
No
leak.
MRCP. You know there is a bile leak. What do you do when there is bile leak?
ERCP, diagnostic and
Yeah, you have to put a stent and decom.
Stent and decompress the system so that it will stop leaking. Okay, right. I think it's 10 o'clock. Praveen,
Yes, sir.
you need to read. Hydrated cyst, you are very poor. Read up.
Yes, sir.
Okay, others, you are okay. Niranjan, final comments?
Sir, good discussion, sir. Yeah, Praveen, you have to be very thorough. You have to answer to the point and you have to respond spontaneously. These are all simple questions. You have already finished theory. You should be knowing all these colicidal agents. Tuck, tuck, tuck. You should be telling because commonly this will be kept. Hydrated cyst and all those things are very common. Kept as for OSCE as well as probably if there is a bedside case, they will ask you in ward rounds.
Yes, sir.
Okay. So, Prashab, Praveen, okay?
Yes, sir. Correct.
Right. Okay. If there are no questions, we'll stop here. Good night, all of you.
Good night, sir.
Good night, sir. Thank you, sir.